Hi, I'm Dr. Susan Anderson, and I'm a clinical assistant professor here at the University of Florida College of Veterinary Medicine. And I actually run our outpatient service here at the college, and I mostly take care of our preventive medicine and wellness for small animals, and I also do our small animal dentistry. So today we're going to talk about vaccination protocols for canine infectious diseases. There's lots of infectious diseases that our dogs and cats are exposed to, and it's impossible to talk to you about them all just today. And so I do have a few references for you that you can use to find out more about these diseases. There are lots of diseases that we don't vaccinate for, and you'll find them in Green's Infectious Diseases of the Dogs and Cats. Burchard and Scherding's Manual of Small Animal Practice is very helpful, as is the most current veterinary therapies, 12 and 13. This will probably give you all the information that you need to or want to have. Okay. So I'm going to talk to you a little bit about the fact that there's been quite a change going on in our profession about vaccination. And so I think it's important for you to know that vaccinations are critical in the prevention and elimination of disease. And generally these vaccinations, our veterinary vaccines, are very safe and quite efficacious, and the benefits far outweigh the risks of giving them. The goal needs to be that we vaccinate more animals in the population, but we vaccinate individuals less often. What we're looking for is a population control of disease. But there have been a lot of concerns over adverse reactions, and so that has been some of the impetus to look at how much we vaccinate our dogs. I think it's important for you to remember that vaccination is a medical procedure, and it really does require all the thought and consideration that any other medical or surgical procedure requires. And you need to educate your clients in the fact that what's important is the physical exam and your expertise as the veterinarian. And you need to explain to them that the real need is that they do need to have an annual health exam, whether or not they get vaccinated. And the way, unfortunately, we've priced our charges in the clinics, we've kind of encouraged the clients to think that the value was in the shot rather than the exam. And so that's something that you need to re-educate your clients about. Now, it's also important for you as the veterinarian that you need to stay abreast of all the latest developments and research. And you need to educate your clients before they find information elsewhere. There's a lot of good information out there on the web and in books, but there's a lot of bad information too. And you need to encourage your clients to come to you for information and not elsewhere. So now we're going to review a little bit about vaccination, kind of get you all up to speed. And so we talk about vaccination, but what we really are trying to do is provide immunoprophylaxis. And so we're trying to enhance a specific immune response in an attempt to provide protection for the animal from disease. And there's a couple of ways to do that. One of the ways that we commonly do that is by vaccination, and the other way would be by passive transfer, and that would be actually giving antibodies to the animal to provide immediate protection. So what are some of the immune defense mechanisms? There's actually a lot of native defense mechanisms that dogs have, and some of them are very simple. Your saliva, your mucus secretions, your skin covering, all of these things help provide the acid in your stomach. They all help provide to the dog some natural immunity. You also have humoral immunity, which is primarily IgM and IgG. You have cell-mediated immunity, which is carried on by your T cells, and then you have your secretory IgA, which is found at all the openings of the body. Now there's two ways, passive and active ways to immunize animals. So passive immunization would be essentially, as we talked about, passive transfer. So what you're doing is actually transferring specific antibodies from a protected animal to an unprotected animal to provide immediate protection. The problem is you are giving a foreign protein, and so there is much of a risk for an allergic or an immune reaction. It gives you very short-lived protection because the the transferred antibodies don't stay around very long, and you have the possibility of transferring disease from the animal with the antibodies to the other animal if you haven't screened for all the possibilities. You can give antibodies in several ways: orally, intramuscularly, intraperitoneally, and sub-Q. This is a great way if you do have young puppies that didn't receive colostrum when they were born, and they're essentially unprotected because they didn't receive any maternal antibodies. And so you actually can give them serum from a protected animal to help provide that early immunity. Now, we also have active immunization, and that's what you are most familiar with. And so that is giving an antigen, which is the antigens are in your vaccine, and it will help produce an immune response. It certainly is less expensive than passive immunization, though it does take time for the animal to develop immunity once they're given a vaccine. However, you get very long-lived immunity. It may be months long, years long. It may actually provide lifelong immunity. It just depends on the disease and the vaccine. Now, in a lot of the papers that you'll read about vaccination, they discuss duration of immunity. And essentially, that is how long does the vaccine last. Now, annual vaccinations were recommended by the AVMA about 20 years ago. However, most of the vaccines at that point were challenged 2 weeks after the last vaccination was given. And then the 1-year revaccination that was put on the label was actually quite arbitrary. There is an exception to that, and that's rabies. And the testing for rabies, they absolutely have to do challenge testing at 1 year or 3 years, depending on the label. And so it does have a much more guaranteed duration of immunity. The problem with a lot of our other vaccines is we don't really know if the vaccine lasts a whole year, or does it last for 3 years, 5 years, 7 years, or a lifetime. And part of the problem is it's very expensive to do those animal studies, not only in monetary means, but also in animal lives, because if you're going to do a duration of immunity study, you need to keep animals, a controlled group of animals, and a vaccinated group of animals for that entire period of time. And then they need to be challenged, and essentially 80% of the vaccinates need to be protected, and 80% of the controls need to become sick and or die. So as you can see, it's probably not a study that's going to be done very often or with very large numbers. Since 1995, however, the USDA has required a duration of immunity for new vaccines. So if there was a vaccine that came out for Bartonella, it would have to have a proven duration of immunity for whatever was put on the label for revaccination. However, if somebody came out with a new distemper vaccine, they wouldn't necessarily have to have a proven duration of immunity to help support whatever their revaccination recommendation was. You'll also see in several papers that they refer to core vaccines and non-core vaccines. Core vaccines are vaccines that really should be given to all dogs, and that includes distemper virus, canine parvovirus, infectious canine hepatitis, and rabies. Those are the ones unquestionably all animals need to get. Now, our non-core vaccines are vaccines that should be given on the basis of risk assessment. How likely is this animal to be exposed to these diseases, and do they need to be protected? Does the benefit outweigh the risk? And those diseases would include canine coronavirus, parainfluenza virus, leptospirosis, bordetella, Lyme disease, and giardia. Now we need to talk a little bit about maternal antibodies and their effect on the ability to immunize dogs. And you have to realize that immunization and vaccination are not the same thing. You can vaccinate a dog and they may not be immunized if they don't develop an immune response. So it's important to know that maternal antibodies are passed in the dog mainly in the colostrum. So 82 to 98% of their antibodies they get in those first 2 days or 2 to 3 days that they nurse. And then they do get some of their antibodies transplacentally. Now humans mostly get theirs transplacentally, but dogs get very, very small amounts of antibodies in that way. And you know that they're only absorbed in those first 1 to 2 to 3 days of life. Now every puppy doesn't necessarily have the same level of protection. It's going to depend on what was the dam's antibody titer to begin with. Did she have a lot of protection or not very much protection? And maybe she had a good immunity to parvovirus and not to distemper. So there's times when we really don't know that. It's going to depend on how much colostrum each puppy gets. You know, you have that little piggy puppy that nurses a lot, and then you have that little runty one that may not get as much colostrum. So all those puppies may not get the same protection. It's also going to depend on how heavily parasitized the puppies are and in what kind of environment they're in. Are they nice and toasty and warm and comfortable and well fed, or are they exposed and they're chilled and they're not getting enough nutrition from the dam? Now we're going to talk a little bit about the different types of vaccines. All vaccines are not equal. So generally we talk about modified live vaccines and inactivated or non-infectious vaccines. Now the modified live vaccines have a few advantages. The modified live is a live vaccine, but it's been attenuated so that it will cause an immune response and protection from disease, but it won't really cause disease itself. So the advantages to using this product would be that it replicates in the host, and so that helps to provide more rapid protection, longer lasting protection, and the modified live vaccines are not as allergenic and we don't get as many reactions because there's not as much antigen in those vaccines where that virus is going to multiply. And it does seem to stimulate cell-mediated immunity much better. Now the disadvantages to modified live vaccine would be that periodically they could revert to virulence, and instead of causing protection and no disease, they potentially could cause disease. It does not happen very often, but it's possible. And occasionally, because of the fact that this virus is multiplying, it can sometimes cause some immune suppression. Now the types of modified live vaccines, there are the older types of vaccines, which are, and I'm just going to go back and double check. Some of the newer types of modified live vaccines would be the recombinant vector vaccine. And so actually what happens is they take the genetic code for the part of the disease that actually produces the immune response or the disease, and they replicate that. And then they insert it into another non-pathogenic virus, like a pox virus or herpes virus. And so then there's just that specific protein, as in the PureVax, and we don't have a vaccine like this for dogs, but there's nothing but protein G in actually the canary pox, and so hopefully it causes a lot less reaction. There are several different types of modified live products. You can give an intranasal modified live product, and you tend to get an immune response within 3 to 5 days. It's very quick. It gives you higher levels of IgA, which is important for diseases that tend to come in through mucous membranes. It tends to revert to virulence a little more rapidly, and you can get some post-vaccinal signs, similar to giving intranasal parainfluenza or bordetella, and you may actually get a mild coughing or sneezing. Same way with cats, and you give them an upper respiratory vaccine. They may get some small clinical signs if you give it intranasally. To give a modified live product parenterally or by injection, it takes a little longer to get an immune response, usually 7 to 10 days initially. You actually get high levels, and this is a little bit of a typo, you get high levels of IgG. It does not revert to virulence as readily as a intranasal product, and you have fewer post-vaccinal signs. So we'll talk a little bit about vaccine reactions a few slides later. Now we also have inactivated vaccines, and some of those are, as we can see, whole agent, which means it's the whole virus or the whole bacteria. It has some advantages. If you use an inactivated or killed product, it doesn't replicate in the host, and so there's not a problem with it ever causing the disease in the host, and so it might actually be safer in immunosuppressed or very young animals in some situations. It does have some possible disadvantages, though, is because you're using a killed product and it's not multiplying or reproducing, it requires more, the body has to see this vaccine more times, so it requires more vaccinations than using a modified live product. It actually causes more allergic problems because if you're using a killed product, it has more antigen there. It also requires adjuvant, which is an immunostimulant, and they tend to have shorter duration of immunity of protection than the modified live products do. There's some newer types of inactivated vaccines. One of them is a purified subunit, and essentially what they do is just take those components of the disease or bacterium that stimulates the immune response, and they replicate those, and then it's given as a vaccine. They're somewhat less allergic than a killed whole agent. There's not a purified subunit vaccine per se for dogs, but the example would be the Leukocyl-2 vaccine that Pfizer makes for cats. There's also a recombinant protein, and so the desired gene that produces immunity is cloned into an organism, say like E. coli, and so it acts like a little factory of this protein, and so it makes lots of the protein that will produce immunity, and then it's purified, all that E. coli is gotten rid of, and so then it's harvested and given as a vaccine. And one of those examples would be Marielle's Lyme vaccine called Recombitech Lyme. Now, I alluded to the fact that not all vaccines will immunize effectively, and there's host factors, there's vaccine factors, and there's human factors involved. Now, some of the host factors, as we said, just because you gave a vaccine doesn't necessarily mean that these animals are going to be protected. If there's some basic immunodeficiency, if they don't have an ability to mount an immune response, they're not going to have a good vaccine response. If they have maternal antibodies present, and I've got some slides later that will show this even more clearly, but maternal antibodies will interfere with the ability to mount an immune response with a vaccine. If you give a vaccination to a puppy that still has lots of maternal antibodies, the maternal antibodies treat that vaccine as the foreign invader. And so it's very busy and it just kind of eats up all that vaccine. And there may not be enough vaccine to actually mount an immune response. But then there may not be enough maternal antibodies to protect the puppy at that point. And so then they're not protected from disease at all. If they're exposed to disease, this is especially a problem in parvovirus, then they may become ill. Age tends to be a factor. Very young animals, very old animals may not have as competent immune responses. If pregnant animals, not a good idea to vaccinate them. If they are running a fever or they have a very low temperature, they may not mount a good immune response. If they're ill, it's not a good idea to vaccinate an ill animal, even though, oh, well, I think I might be protecting them from disease. Not a good idea. They need to be healthy and parasite-free if you're going to vaccinate them. If they're already incubating the disease that you're going to vaccinate them for, probably not going to help them. Certain drugs may suppress the immune response, cortisones, some of the antifungal drugs. You need to be very careful about what drugs they're on. If they're on antibiotics and you give a Bordetella vaccine intranasally, well, that bacteria, the Bordetella, is what we call an avirulent live vaccine. And if the animal's on antibiotics, you may actually kill the organism that's in the vaccine, and then you don't get any protection. If the animal's malnourished, they're also not going to mount a good immune response. We talk about anesthesia and surgery potentially causing some immunosuppression. There's a difference, though. I mean, if you gave a booster vaccination to an otherwise very healthy puppy that had been vaccinated before and it was going to get spayed or neutered, it's probably not a problem. If you're going to vaccinate an animal that has a pyometra or that's very ill, probably not a good idea, even though that pyometra animal is going to get spayed. It's very different from the healthy routine ovariohysterectomy. We talked about some of the vaccine factors that may affect immunity. If the vaccine is improperly stored or mishandled, it's gotten warm or it's gotten frozen, it's not necessarily going to be effective. Also, there may be some biological variations in the vaccine, and even though they're quite closely tested, is the vaccine too virulent, or is it not virulent enough to produce an immune response? Also, there are sometimes different strains, and we'll talk about this with leptospirosis, that there's not always cross-protection. If you vaccinate with one strain and they are exposed to another strain, sometimes they're not always protected. And sometimes in the face of overwhelming exposure of the disease, no vaccine will help. Now, certainly there are also human factors. What are the mistakes that we make in our veterinary practices that will not make our vaccinations as effective? Do you have a good hospital protocol? Are you vaccinating at appropriate times at appropriate intervals to get a good immune response? There is such a thing as vaccine interference. When you give a vaccine, you also stimulate interferon production. And if you give two vaccines too close together, the body may not be able to recognize that second vaccine. So standard of practice, general rule, don't give any vaccines more frequently than 2 weeks apart. The exception to that may be giving an intranasal vaccine if you had to, but generally you need to think you can give multiple vaccines on the same day at the same time, but don't give a vaccine today and then in 3 days and then the next time. We certainly see that as more of a problem with breeders. You get a puppy in for its first visit to you as the veterinarian, and all of a sudden you look at the records and, they got a parvovirus this day, and 3 days later they got a distemper, and a week later they got something else. I'm never sure quite what those puppies are protected against at that point. So remember, no more than 2 weeks apart, or no less than 2 weeks apart. Were the vaccines appropriately mixed together? Did you put the right diluent into the right dry vaccine? Don't mix vaccines together if they weren't designed to be mixed together. You wanted to put it all in one shot because it was a mean dog, and you only wanted to stick it one time with a needle. Well, you can't mix that distemper parvo combination vaccine with that Bordetella vaccine with that rabies vaccine unless they were manufactured that way. And again, we talked about the fact if the animal's exposed at the time of vaccination, you're not going to protect it. Are you giving the vaccine in the right place? Excuse me. If it's a vaccine that's designed to give intranasally, you can't give it parenterally. It's a very big problem with Bordetella vaccine. If you use too much disinfectant on the skin, you can inactivate the vaccine, and certain antibiotics or immunosuppressive drugs may immunosuppress the animal so that they can't respond. Now, we talked about the fact that more and more pet owners are concerned about vaccine reactions. And there's always going to be some reaction when you give a vaccine. Sometimes it's as simple as a local problem. There's just a little bit of pain or swelling at the site of the vaccination. Generally, they may have kind of a mild systemic reaction. While that modified live vaccine is multiplying, they get kind of achy and febrile, and they just don't feel well. Just like when you get your flu vaccine, you kind of know that you just don't feel well. You don't get the flu, but because your immune response is cooking, you just don't feel well. Certainly, you can get, if you vaccinate a pregnant animal, you can get fetal resorption or abortion. You can get immune complex disease, antigen and antibody complexing, and it can be deposited in the kidneys and the eye. You can have anaphylaxis, and that's a big problem with killed products because they're very allergenic, and probably the most common one we have a problem with is leptospirosis vaccine. Again, if the vaccine is not attenuated enough, it can cause disease. You can occasionally stimulate immune-mediated hemolytic anemia. In cats, we worry about vaccine-induced neoplasia at the site of vaccination, fibrosarcoma or one of the sarcomas. Also, if you're using a vaccine that has multiple doses in one vaccine, you have to be careful that you don't contaminate that vaccine and then actually be giving bacteria or virus to the next dog. Occasionally, there have been manufacturing problems where, as they're growing the vaccine, it gets infected with another virus, and that's been a problem with blue tongue virus. Sometimes we see a reaction when you vaccinate cats for calicivirus, and they actually get kind of a limping syndrome. They can get it from the actual disease, but they can also get it from giving the vaccination. And then sometimes we can see some diseases of young Akitas associated with vaccines. And if you want to know more about this, the Green's Infectious Diseases is a great reference. We talk about where should we vaccinate dogs. Part of this has come from the recommendations by the American Association of Feline Practitioners on where to vaccinate cats. And so we've just kind of extrapolated it into dogs. But it's important for you to know what vaccine you put where on the animal, and if they had a reaction, you're able to record that. So generally in our hospital, we give the distemper combination vaccines in the right shoulder. Rabies is accepted to be given in the right rear leg. It can be given sub-Q or IM. You can just, you need to look at your manufacturer's label. Any others, you just need to record the site in your record. And then you also, in your record, your medical record, you need to record the manufacturer, the type of vaccine you used, and the serial number. And now all these vaccines have these nice peel-off labels, and so you can peel those right off and stick them in the record. You still need to write in, however, where that vaccine was given. Even if you have a standard protocol in your hospital, if it's not in the medical record, it didn't happen. So for your protection, you do need to write down where you gave the vaccine. We also talk about now that animals probably should be vaccinated on the basis of their risk. So you want to do risk assessment. And I've kind of broken this out in that, you know, are these animals that are in a shelter or breeding animals in a group population? You know, or because shelter medicine is certainly different than the individual dog. Do you have the dog that runs loose, roams the neighborhood, roams the hills, the dales, comes in contact with who knows what kind of other animals and what other infectious diseases? Do you have the dog that's outside, but it's really in a fenced-in yard, and it may go out on a leash walk, but it's not running free? Do you have that, what we call kind of outdoor socialite? It goes out strictly on a leash, doesn't really encounter other dogs. Do you have the indoor socialite, multiple animals in the household, but they still remain primarily inside? Do you have a single pet that may rarely go outside, and then you have the really pampered pet, you know, never goes even outside to go to the bathroom, only uses a little doggy litter pan or papers, never comes in contact with another four-legged soul. So all those things, you need to look at the lifestyle of the pet in order for you to recommend what vaccinations to give. We give general recommendations on types of vaccines to give, but you need to tailor that to each individual patient, and that's one of the reasons that your clients need you as the veterinarian. So now we're going to talk a little bit about the diseases that we do vaccinate for. Canine distemper. You know, we vaccinated for canine distemper for a lot of years, and if you're not living in a kind of an urban population or doing a lot of shelter medicine, you may not have ever seen a case of distemper, and it may be a long time before you see one. Canine distemper is in the family of Paramyxoviridae, and it's a morbillivirus. And in that same classification is not only canine distemper, but regular human measles. They're actually very closely related. And there's lots of hosts that can carry canine distemper. So besides the dogs, you can see seals, ferrets, skunks, foxes, minks, coyotes, and wolves. They can all become infected with canine distemper. So how is canine distemper transmitted? The virus is shed in pretty much all of body secretions, and the primary source is kind of an aerosolization of the virus. It's seen more often in young dogs kept in groups, so you are going to see it in more of a shelter-type environment or where puppies are kept all together. And if the animal does recover from distemper, they usually cease shedding the virus within about 1 to 2 weeks once they recovered. The virus is not very stable in the environment, and so it only survives hours to days if it's not inside the dog. And it's you're fairly well able to disinfect surfaces from canine distemper. But it is a very serious disease. Animals may become infected, and actually their immune response sees the virus, and they may indeed recover. But if they're becoming sick, you may see them being very kind of a malaise. They're anorectic, they don't want to eat, they're running a fever. And then you start to see that kind of snotty nose thing going on. They get a rhinitis and a conjunctivitis, and it may indeed develop to pneumonia. They also can have vomiting and diarrhea, which very much complicates this young dog that came to you from the shelter, and you're trying to decide whether it has distemper or whether it has parvovirus. They tend to get a keratoconjunctivitis, conjunctivitis, so they get this horrible debris in their eyes, and they can also get a chorioretinitis. So when you do a fundic exam on these animals, you actually can see the fundus around you can see the inflammation around the fundus in the eye. This virus likes the nervous system, and so once it enters the nervous system, you can see seizures. They can become ataxic. They don't walk well, and then they can get the classic, what we call myoclonic seizures, that contraction seizure. They also have what we call a chewing gum seizure, and their mouth just moves and they look like they're chewing gum. But that's kind of the classic description of a distemper seizure. They can also, once they've recovered, develop these very classic kind of gold medallion chorioretinitis lesions. So sometimes you can actually look at a dog by its fundus exam and know that they were previously infected with distemper. They can also have problems with developing enamel on their teeth if they're exposed to distemper as a young dog and recover. They can have very much what we call enamel hypoplasia and have this pitted enamel. So almost any febrile event can cause this in puppies. So just because you see enamel hypoplasia or hypocalcification in a dog doesn't always mean they had distemper. They could have had some other disease. How do we diagnose distemper? Often it may be just by the clinical signs and the fact that you know that the animal has not been adequately vaccinated. You still are going to do your basic tests. Your CBC may initially show low lymphocytes and then may later show that you have lots and lots of neutrophils. On radiograph, you may see the pneumonia, and if you do a CSF tap, a cerebral spinal fluid tap, ideally you would see increased proteins, and you could find the distemper antibodies. You can do virology, and you'd be looking for intracytoplasmic viral inclusion bodies, and potentially you can do virus isolation, but it's not that common. You do have to know, though, if you get a negative result, it doesn't totally rule out the disease. If you do serology and you're looking for titers, you're looking for a rising titer. A single titer is not really going to tell you anything. You're going to do a titer and then a titer again in 2 to 3 weeks if the animal's still with us, and you're looking specifically for IgM. And it only suggests that they have distemper. It's not absolutely definitive. How do we prevent distemper? We're going to use a modified live vaccine, ideally, and you're going to start vaccinating at 6 to 8 weeks of age, and then you're going to booster every 2 to 4 weeks until the animal is 14 to 16 weeks of age, or until the dog is 14 to 16 weeks of age. You need to booster in 1 year regardless, and then depending on your hospital's vaccine protocol, what you feel like the risk assessment is, then you're going to vaccinate after that every 1 to maybe 3 years. If you're worried about maternal antibody interference with distemper, you can actually use what we call a distemper-measles combination vaccine. As you saw on the previous slide, that measles and distemper are related viruses. And so if you give a combination distemper and measles vaccine, if indeed you have lots of maternal antibodies, which won't allow an immune response by the distemper part of the vaccine, you will get some protection because the measles is so similar and can help stimulate an immune response. And there's not a problem with maternal antibody interference. You do have to give 2 doses of this, however, to start getting protection. So there is that period of time where you're not protected. The vaccine is given intramuscularly, so you need to be sure to read the label. And then you can follow up with regular modified live distemper vaccines as the puppy gets older. There is a recombinant vector type of distemper vaccine that's made by Marielle. We're a little uncertain about how long the immunity lasts, but it is recommended to booster it annually. Now we're going to talk about canine infectious hepatitis. It's also called canine adenovirus type 1. There is also a canine adenovirus type 2. And type 2 actually causes a respiratory disease, and it's related to the kennel cough complex. The adenovirus type 2 actually provides protection for type 1, and we see lots fewer vaccination reactions by using type 2 vaccines. But we're protecting for hepatitis. And we don't see a lot of canine hepatitis anymore, but it's still out there, and you stop vaccinating for it, and you'll still potentially see it. Transmission of this disease is primarily oronasal. It's shed in all the body secretions, and it's shed for a long time, even after these animals recover, up to 6 to 9 months. And it's actually very resistant to inactivation and disinfection. So once it's in the environment, it's hanging out there waiting to find its next victim. What are the clinical signs of infectious hepatitis? The per-acute or very immediate severe signs, young puppies are exposed and they can die within hours if they're not protected. And as you can see by this picture, on the acute course of the disease, which can last about 5 to 7 days, it's common to see vomiting and diarrhea. And they also have this abdominal pain. They're very uncomfortable. With this particular disease, you can get what we call blue eye. You get corneal edema because there's antigen and antibody complexes that deposit right in the cornea. It can also be a reaction of the vaccine, but you can see it with the disease. They also get an anterior uveitis, and you get some central nervous signs, usually secondary to the fact that they've got hepatic encephalopathy because it's affected their liver, or they're very hypoglycemic, or they actually end up getting an encephalitis. How do you diagnose it? Again, a lot of times it's the fact that you have the clinical signs of the disease in a relatively unvaccinated individual. But if you're running some tests on your chemistries, you'll see an increase in alanine transferase and alkaline phosphatase. You can see a thrombocytopenia, and then you may see ecchymosis and bleeding, and then progress to DIC. You can see protein in the urine, and you can also do serology and virus isolation or histopathology on tissues in order to definitively try to diagnose the disease. Certainly this is one that's much easier to prevent than it is to treat. We use a modified live vaccine. And again, we talked about we're protecting them from adenovirus type 1 by using type 2 vaccine, because the type 1 vaccine can actually cause an anterior uveitis, corneal edema, or nephritis. Just like distemper, we start vaccinating at 6 to 8 weeks of age and every 2 to 4 weeks until 14 to 16 weeks. This may sound a little bit like a broken record by the time we're over all of this. We're going to booster this particular vaccine, and it's usually given in combination in 1 year, and then we're going to booster every 1 to 3 years, depending on the risk factors. Now we're on to canine leptospirosis. It's one of the non-virus diseases. This is actually a bacterial disease. It's in the big class of Leptospira interrogans scintillata, and there are several different serovars of this type of leptospirosis. The common ones that infect dogs are Bratislava, Ictohemorrhagica, Pomona, Canicola, and Grippotyphosa. And this is just a picture of that little spirochete organism that is leptospirosis. How is lepto transmitted? It's by direct contact, and it's usually by exposure to infected urine, which can be shed by an infected dog, or one of the other carriers tend to be rodents. That you can have venereal contact, you can have contact with infected placenta, you can get it from infected bite wounds, and ingesting tissues from an infected animal. The indirect contact would be if there is contaminated water sources, bedding or the soil, and if it's been very rainy and wet. It's a place where the leptospiral organisms like to live. And we tend to see that rodents and wild animals tend to be the reservoirs for this particular disease. So the clinical signs of leptospirosis are important. And this is an important disease because it's one of the zoonotic diseases. This is a disease that humans can get. It's fairly severe, and the organisms are shed for a long time in the animal's urine. So You have to be very careful when you're handling these animals. It causes fever, depression, they don't eat, they have muscle pain. They're very unhappy. They become quite dehydrated. You can see these kind of congested mucous membranes. They don't have good capillary refill time. They can go into acute renal failure because the leptospirosis affects the kidney and the liver. And they can also have acute hepatic failure. And again, we can see DIC and bleeding tendencies. For diagnosis, if you do a CBC, you may see low white cells to start with, and then you may see neutrophilia and a decrease in the platelet numbers. On urinalysis, you can see proteinuria, then you can see actual bacteria in the urine, and then bilirubinuria as the liver becomes affected. On serum chemistries, you're going to see an increase in BUN, creatinine, the phosphorus, all the liver enzymes, and again the bilirubin. These animals often can present quite icteric. In order to further diagnose the leptospirosis, you need to go to serology, and you're going to actually do a microscopic agglutination test. What you need to see, though, is a rising titer. You need to take a blood sample initially and then in several more weeks, and you need to see at least about a 4-fold increase in the titer to say that they're really exposed to leptospirosis. You can run single titers. If you get a 1 to 300 titer, it's probably suggestive. If you get a 1 to 1,000, it's highly suggestive that the animal does indeed have leptospirosis. So how do we protect for it? We talked about the fact that this vaccine is potentially allergenic. And when we immunize with leptospirosis, it tends to reduce the incidence and the severity of the disease, but it does not prevent the carrier state. So animals can indeed become carriers of leptospirosis even though they're not sick themselves. The vaccine does tend to have a very short duration of immunity. It's the one vaccine that we can say probably only lasts about 6 to 8 months. And again, it's very highly allergenic. It can cause anaphylaxis, type 1 hypersensitivity, and you need to treat accordingly and not vaccinate for leptospirosis again. These animals can present minutes after they've been vaccinated or several hours, and they can go into complete vascular collapse with trouble breathing, white mucous membranes. And then they can have something as simple as hives or urticarial reactions. We do seem to see this reaction more often in very small dogs, toy dogs, but more so in dachshund, miniature dachshunds than any. So I just don't vaccinate miniature dachshunds for this disease. It tends to be, if it's combined with other killed products, say like coronavirus, it can certainly cause more reactions. So you have to be aware of that. Again, there's no cross-protection between serovars. And so if you only vaccinate for canicola and hemorrhagica and they're exposed to Bratislava, there's a problem because they won't be protected. Because this is a killed vaccine, it's recommended not to start vaccinating until these puppies are 9 weeks of age or greater. Their immune system is not quite as developed. This is an allergenic type, an allergic type vaccine, and the puppies are much more able to tolerate it if they're a little bit older. So it shouldn't be given at that 6 or 8 week vaccination. You should give it when they're 9 weeks or greater. And then again, you're going to vaccinate every 2 to 4 weeks until they've had 2 or 3 doses of vaccine. So by the time usually they're 14 to 16 weeks, they'll be finished with their vaccination for lepto. Most of the current vaccines on the market have the serovars ectohemorrhagica and canicola in them. Fort Dodge, however, has come out with a newer product that not only has those 2 serovars, but it also has Gripo typhosa and Pomona in it. And so if you're in an area that has known leptospirosis and you've identified what serovars have been found in your area, you may have to go to your state laboratory and ask, but that will help you decide to choose which vaccine to choose. And do you see leptospirosis in your area at all? And does the benefit of vaccinating outweigh the risk of the vaccine reactions? And that's up to you to decide. Now we're going to talk a little bit about canine infectious tracheobronchitis. This is also known as kennel cough, and then it's also known as canine cough complex. It's not just one disease. It can potentially be a combination of several different diseases or just one of these. So the viruses that are involved in the cough complex would be parainfluenza, adenovirus type 2, distemper, and canine herpes virus. The bacteria that we see that are involved are Bordetella bronchoseptica, plus minus whether or not Streptococcus is involved, and we may actually see some mycoplasmas involved. How is this transmitted? It's very contagious, and it's spread via aerosol. So one dog coughs on another or coughs nearby, and it's spread. It's also spread by fomites. Fomites would be food bowls or blankets or the kennel floor. And what are the two worst fomites in your hospital? These things right here. You cannot wash your hands enough in your hospital environment to prevent the spread of diseases, not just kennel cough, but all the rest of them too. The incubation for this is about 5 to 7 days, though it can be as early as 3 and as long as 10. And obviously we know that group confinement is a risk factor. So animals that are boarded, animals that go to dog shows, animals that spend lots of time at the park, these certainly are animals that are more at risk for getting kennel cough. Usually the clinical signs are quite mild. We see a higher incidence in the summer and the fall. You get that horrible paroxysmal honking cough, you know, and then they cough, and then they make this big gag and retch, and then they may end up bringing up phlegm. Sometimes your clients will come in and describe that the animal is actually vomiting. It's not vomiting, it's really coughing and then coughing up all this phlegm. It tends to get worse when they're active or when they get up, and that tends to stimulate a cough. When you're examining the animal, you can get a cough if you palpate along their trachea. It's easy to get them to cough. But the dogs with mild disease are usually bright, alert, active. They're still eating. It's just that they're coughing and keeping themselves and their parents up during the night. You can indeed get a very severe form of kennel cough. It's not that common. It tends to be in very young, unvaccinated puppies, and it can come from breeding areas, shelters, and they can become quite depressed, not eat, run a fever, and actually get pneumonia. They have a very productive cough, not that dry, hacking type cough, and it can be fatal. So if they're not bright, alert, and wagging their tail, you need to be fairly aggressive with their therapy. What I neglected to mention before this, you can kind of see that we haven't talked anything about treatment. This lecture would go on forever if we talked about treatment of all these diseases. Treatment of parvovirus could be a whole lecture in itself. And so that's why you need to rely on some of your references to help you with treatment. But if you can diagnose it, you can always look up the treatment. So diagnosing kennel cough, oftentimes you're going to diagnose this on the basis of your clinical exam and the potential exposure. Oh yeah, the neighbors next door have a dog that's coughing. You're probably not going to do a lot more other testing. If you run a CBC, the mild form, the CBC may be normal, or you may see a stress response, you know, a little bit of a neutrophilia. In the severe cases, though, you'll see a neutrophilia, and you'll actually have a left shift. You can do cultures. You can actually use a nasal swab, or you can do a tracheobronchial swab, either from a wash, bronchoalveolar lavage. You can put down a trach tube and then culture the end of the trach tube. There's lots of different ways. And usually you're going to be culturing for bacteria, i.e. the Bordetella component. If you radiograph these dogs, if they have mild disease, you may not see a lot of changes. But if you have a severe disease, you may see an interstitial and alveolar pattern. And in this particular radiograph, if I can get my pointer to work, you can start to see all this consolidation here, and then you start seeing some nice bronchograms in here. So if the animals seem quite sick, then you indeed may need to radiograph them. And you can do cytology if you've done a swab, or if you've done a tracheal wash, you can do cytology. So what do we do for prevention of these diseases? Well, obviously in our combination distemper, adenovirus, parainfluenza, parvo, lepto combination vaccine, we're vaccinating, when we vaccinate for the hepatitis, we're vaccinating for parainfluenza. But we can also use an intranasal vaccine. And It's modified live parainfluenza. It's almost always combined with Bordetella, and it's a virulent live form of Bordetella. It tends to stimulate better IgA, so you get antibodies produced right at the nose and the throat and the mouth, so helps provide immediate protection. You get cell-mediated immunity and interferon production, and you don't have maternal antibody interference, so you can actually use the intranasal vaccine on animals that are quite young if they're at risk for exposure. Actually, as early as 3 weeks, so I don't think I've ever vaccinated one that young. You can actually get protection with the intranasal form with 1 dose of vaccine, and you want to give it when the dog is a puppy, when you've seen that they're at risk, or if you're giving it before they board, I'd probably try to plan on giving it 1 to 2 weeks before you actually board so that they're protected before they go into board. You get fairly rapid onset of protection, and sometimes you'll get some mild clinical signs. If the virus starts to replicate, the bacteria starts to create a little bit of infection before the immune response kicks in, you may actually get some mild coughing or sneezing. And you need to warn your clients that they may see some mild forms of the disease. You can use an injectable form, and as we talked about, that's found in the combination vaccine. It's again modified live. They need to receive at least 2 doses of the vaccine, 2 to 4 weeks apart. It's often given in that combination vaccine every 2 to 4 weeks until they're 14 to 16 weeks of age. The parenteral vaccine tends to protect against clinical signs, but they may indeed still shed the virus if they're exposed. And it takes a little bit longer for protection than the intranasal form. There are a couple of very good articles in the last year or so of JAVMA from the veterinary school at Saskatoon talking about protection with vaccines against Bordetella, and they're quite interesting. And actually, it tells us that the parenteral and the intranasal vaccines are probably equally protective, but in a real risk situation, you may want to actually give them both, separated by 2 weeks each, and you may actually get better protection than one or the other. Now, we talked about that the Bordetella vaccine is combined with the parainfluenza, and again, the intranasal product produces IgA within about 4 days, and it protects against clinical disease and shedding. We already talked about that it can cause some mild post-vaccinal signs, and with the intranasal product, you get protection with 1 dose. If you give the parenteral dose, it's actually killed bacteria, so you do have some risk of a local vaccine reaction, maybe some anaphylaxis. You need to give at least 2 doses of the vaccine in order to be protected, given 2 to 4 weeks apart, and you do need to give it then so that they receive their last vaccine at least 1 to 2 weeks before boarding. You do need to remember that animals that are very sick with Bordetella, there is a small amount of a zoonotic potential. Small children, especially if they have their face in the dog a lot, can potentially get Bordetella also. Now we're going to talk about parvovirus, which is the one we all hate to see or treat, a disease that causes severe vomiting and diarrhea. We started to see parvovirus for the very first time in the late 1970s, and it was isolated as parvovirus 2, type 2. And then since 1980, it mutated a little bit, and now we see the strains parvo, CPV 2A and 2B, and we mostly see parvo 2B at this time. It has a fecal-oral transmission, and the problem with parvovirus that you need to remember is that virus survives many months in the soil or on surfaces. There's a lot of potential spread by fomites and in contaminated environment. That's another reason why you don't want to take young puppies that are not well vaccinated yet to public parks and areas where lots of dogs congregate, because there potentially is lots of parvovirus in that soil. They essentially will start showing signs in about 4 to 7 days post-exposure, and we mostly see disease in puppies or in dogs less than a year of age, and certainly if they're less than 6 months of age. So this is a disease of young dogs, not a disease of older dogs, for the most part. you know what the signs of parvovirus are: intractable vomiting and diarrhea. They don't eat, they're depressed, they're running a fever, and they become dehydrated quite easily. Once they've disrupted all that epithelial lining of their intestinal tract, they're very subject to endotoxemia and sepsis. They become very hypothermic. They lose lots of protein. They can become icteric. They can have DIC, and we all know that parvo puppies, they're very sick, can die. There are some breeds that we see more commonly with parvo than others, and most people do know we see it in Dobermans and Rottweilers, but we also can see it more in Pit Bulls, German Shepherds, and Labradors. We think that it tends to be somewhat familial, that there may be some families of dogs that are more susceptible, and that some seem to have more maternal antibody interference than others. And those maternal antibodies hang around longer, and so we need to vaccinate them a little differently. When we're trying to diagnose parvovirus, we tend to run a CBC. Usually their white blood cell counts are very low, 500 to 2,000 per microliter. They just don't have many white cells to fight off any disease. When you run their chemistry panel, we can see electrolyte imbalances. They're usually very hypokalemic. They can become azotemic. Their bilirubin is increased, as is their ALT and alkaline phosphatase. On radiograph, it's relatively nonspecific, but you usually do see gas and fluid distension, and you need to differentiate this from a foreign body obstruction or some other GI problem. In order to diagnose it, you want to run virology, and you're going to run an ELISA test on fresh feces. It's pretty definitive, but you do need to remember you can get false positives, usually from vaccine virus. Within about 5 to 12 days of being vaccinated, they can actually shed vaccine virus in their stool. And sometimes you can get false negatives if they've just kind of worn out how many antibodies they've produced, or it's further along in the disease. So how do we prevent parvovirus? We talked about the fact that there is maternal antibody interference, and it does create a period of susceptibility. Now, I'll show you a graph in just a minute that will explain this a little bit better, but there is a period of time, and it's true for every disease, but we see it more with parvovirus, where they have enough antibodies to prevent them from producing a good immune response when they're vaccinated. Because as we talked about before, once you give them that vaccine, the antibodies that are there see that vaccine as the foreign invader. And so then there's not enough vaccine virus there to stimulate an immune response. But they don't have enough maternal antibodies then in order to protect them from disease. And so if they're exposed to parvovirus in that period of time, they're susceptible, and they very well can get sick. And so that's one of those things that you have to explain to clients, because they don't really understand. But gee, doc, my dog was vaccinated for parvo. Well, one vaccine or two vaccines, especially in the face of maternal antibodies, may have provided no protection for those puppies. Parvovirus comes in killed and modified live. I'd probably recommend using a modified live virus vaccine more than I would have killed. There's two types of parvo vaccines that are available. The conventional vaccine, in the problem breeds we talked about, you probably need to vaccinate out to 18 to 22 weeks, because the maternal antibodies hang around longer, and it's going to be a long time before you're able to mount an immune response. But there are some breeds that, for whatever reason, seem to never really get protected. And again, it seems to be a familial problem. We do now have a potentiated vaccine, or what we call a high titer vaccine. And now every vaccine company pretty much has a high titer parvo vaccine. The reason why it's beneficial is that it has 100 times more modified live parvo in it, and it's gone through tissue passage less, and so it's more virulent. So there's much more parvo vaccine available to stimulate an immune response. So even in the face of maternal antibodies, there's still often enough vaccine to stimulate an immune response. So it tends to shorten that period of susceptibility. Most of the labels say that it overcomes maternal antibodies by 12 weeks, but because we have those problem breeds and who knows how many crosses, or for whatever reason an animal didn't respond appropriately to vaccination, it had parasites, it was sick, it had some other problem, or maternal antibody interference, I usually recommend vaccinating for parvo with a high titer product out until 16 weeks for all dogs, and then you can guarantee that most of them will indeed be protected. Now I do have, this is a graph essentially of the period of susceptibility. Now that we've got our little pointer back, on the vertical axis you have the antibody titer, how many antibodies they have, and here along this axis is time, or the age of the puppy in weeks. And this line right here is the amount of antibodies that's required to provide protection for the disease. And this level of antibodies, anything above this level, will interfere with immunization. So puppies are born right up here with this amount of antibodies, and over time they finally start going away. And so you can see here on this particular dog, once it's out here, it's between 8 and 10 weeks, and this animal is quite well protected, but if you gave a vaccine here or here, probably didn't do anything. But here we're in that susceptibility portion. Animals up in this area would be protected from disease. Animals below this area, you could mount an immune response. So on this particular dog, from about 9 weeks to 18 weeks, if you vaccinate it, you can see here at 12 weeks or here at 15 weeks, you're not going to produce an immune response. So if they're exposed to parvo in this window, they're going to get sick. And depending on if they're exposed over here, they have more antibodies, they may not get as sick. If they're exposed over here, they may, get very sick. Let me go back. And then at this point, in this particular dog, the antibody level drops off at about 18 weeks. It's given a vaccine, and then you can see it mounts its own immune response. And so this is the picture with a conventional vaccine. And now to see what it looks like with using the potentiated or the high titer vaccine, it's made this interval less. In other words, the level of antibodies where you can produce immunity is higher. So as this animal starts losing its maternal antibodies, here's the area where it's susceptible to infection, but you see you've shortened it. So instead of being almost 9 weeks that they're susceptible to parvovirus here, you can see that the area that they're susceptible is about 3 weeks. So that's much easier for the owner to help keep that dog out of harm's way until at this point you can see at 12 weeks where it'll mount its own immune response. So now we're going to talk about canine coronavirus. How coronavirus also causes vomiting and diarrhea, but it's on a much more mild scale than parvovirus. It does have a fecal-oral transmission, just like parvovirus, but it tends to be localized more to the intestinal tract rather than parvovirus, which is a systemic disease before it ever localizes to the GI tract. The signs are often subclinical, except in areas where you have a severe outbreak, maybe in a kennel situation or a shelter situation. And coronavirus can be shed in the feces for months post-infection. The clinical signs may be totally asymptomatic. You may not actually see these animals become sick at all. You may see them have vomiting and diarrhea. They usually are not running a fever. If it's mild, you're probably going to treat these animals symptomatically. They're going to recover. You probably don't need a definitive diagnosis. But if you're seeing a lot of vomiting and diarrhea, or they're quite sick, you're going to run your CBC, your chemistries. You may or may not see big changes. But in order to really diagnose coronavirus, you need to do EM or electron microscopy on fresh feces. You can do some virus isolation or PCR, but those are a little harder to find commercial labs that can do that. But in order to say that you have coronavirus, you really do need to have a definitive diagnosis. It's a disease to prevent. I feel that in most cases, and it depends on who you read, but it's primarily a disease of very young puppies. Puppies that are maybe only 6 or 8 weeks of age or younger. And so they're mostly protected by their maternal antibodies. By the time you see them, you may not make a lot of difference by vaccinating. It is important, however, if you're going to have a breeding bitch, they need to be well vaccinated for coronavirus so that they can pass on their maternal antibodies to the puppies to protect them. Most of the vaccines that are available are in chilled form, so you have to realize that you may see some vaccine reactions, and they may be worse if the vaccines are combined with leptospirosis. To protect against coronavirus, you actually need mostly IgA and cell-mediated immunity, and measuring a titer for, or an IgG titer for coronavirus may not really give you a true measure of how protected these animals are. Again, you're going to give these dogs at least 2 vaccines, 2 to 3 weeks apart. If you started vaccinating them at less than 12 weeks of age, you're going to probably have to give a 3rd dose. So if they're less than 2 weeks or 12 weeks of age, you're going to vaccinate them, and then they're going to receive 2 more vaccines once they're over 12 weeks of age. Talk a little bit about Lyme disease. 99% of the cases of Lyme disease occurs in a very limited part of the United States. In the Northeast, the Mid-Atlantic coast, the upper Midwest, around the Great Lakes, and on the West Coast. We really don't see true Lyme disease in Florida. We have had a few Borrelia organisms isolated, but they were not Borrelia burgdorferi that causes Lyme disease. Most of the vaccines available are chilled whole cell vaccines, but we can also have a recombinant outer surface protein or OSA vaccine, and we probably do get protection in naive animals. However, once animals are exposed to the disease, the vaccine will have no benefit. Also, once you've vaccinated these animals, they will test positive for the disease, so it's difficult to separate out vaccination from exposure to the disease, and you actually have to do a Western blot test to differentiate. Probably here in Florida, the most important thing we can do is tick control, and tick control it even in the areas where the disease is prevalent. Tick control is very important because this disease is transmitted by ticks, and it requires usually 24 to 48 hours of feeding before the organism is transmitted. I'll go back. Here in Florida, certainly we have a lot of tick-borne diseases, so more than protecting for Lyme disease, we're going to protect for Ehrlichia and Rickettsia. Here in Florida, I don't recommend Lyme vaccine. If the animal is living in an area where they're at risk of exposure in the Northeast, Mid-Atlantic coast area, then I would recommend Lyme vaccine, but really not here in Florida. There is a vaccine to protect against Giardia. You know that Giardia is that little protozoan that can cause relatively severe diarrhea in dogs, but dogs can shed Giardia in their stool and actually be asymptomatic. Fort Dodge makes a vaccine called Giardia Vax. They recommend vaccinating starting at 8 weeks and repeating it in 2 to 4 weeks. They do recommend annual revaccination, and they have shown the vaccine to have a 1-year duration of immunity, and they have done a challenge study to show this because it's a relatively new vaccine. You do need to use this vaccine really only based on risk assessment. You might have a kennel or a shelter that really seems to see a lot of Giardia, in which case I'd recommend the vaccine. I would probably not recommend the vaccine for your average client single in the household. The vaccine does seem to prevent clinical disease and reduces the severity and duration of the cyst shedding. So if indeed you have a problem with Giardia, then you might want to consider the vaccine. And last but not least, we want to talk about canine rabies. Rabies is certainly a very important disease because it's zoonotic to humans and can be almost 100% fatal if humans contract it. It's a rhabdovirus of the genus Lyssavirus. It's transmitted in the saliva and usually from a severe bite from a rabid wild animal, which includes skunks, raccoons, bats, and foxes. We see it transmitted then to our pet population, dogs and cats, and we actually see more rabies in cats than we do in dogs. The virus is not stable, though, outside the host and does not last long and is easily taken care of with disinfectant. So in the face of a bite wound, one of the first most important things is lots of copious amounts of soap and water. when a rabid animal bites another animal, the virus tends to travel from the bite along the peripheral nerves to the brain. And then it travels back along the nerves from the brain to the salivary glands and some of the other tissues. The incubation time is actually somewhat variable. It can be as short as 2 weeks, and it's usually between about 2 to 8 weeks. But it can have an incubation for as long as 24 weeks, which makes it a little bit problematic. The virus shedding, however, usually begins in the saliva less than 10 days before there are clinical signs, which essentially is why there's a 10-day incubation period or quarantine period for animals. If indeed a dog bites you, if it is rabid, that if you confine that animal for 10 days, somewhere in that 10 days, if it was going to have rabies, enough to transmit it with you because it was in the saliva, it'll show signs in 10 days. It's not to say it couldn't get signs of rabies weeks and weeks down the line, but at least at that point in time, it probably was not shedding virus in the saliva to be transmitted. Once there are clinical signs, death usually occurs in about 3 to 7 days. The kind of beginning or the prodromal phase is when you start getting these non-specific kind of erratic behavior changes. They may run a fever. You may or may not pick up this sign. They kind of have slowed corneal and palpebral reflexes. They're just kind of not doing right. And then classically, if you get the furious phase of rabies in about 2 to 4 more days, they're very irritable. They bark. This is when you start seeing them become very aggressive. They don't seem to know their friends and family. They may have some ataxia, and they may start to seizure. And then we get to the paralytic phase in another 2 to 4 days, and that's when they start getting paresis and paralysis, and they start getting laryngeal paralysis, so you hear a change in the sound of their bark. Once it's affecting the cranial nerves that are supplying the face and the tongue, that's when they have trouble swallowing, and you start seeing the foaming dog is kind of because of the fact they can't swallow, and they get all that saliva collected. And then they can start to fall into a coma and then death. And then you can get atypical forms of rabies which don't follow the plan, and the time frame may be much longer. So it's one of those things that needs to be on your differential when you have unusual neurologic disease. You have to keep rabies in the back of your mind. In order to diagnose rabies, we still have to submit the animal's head for examination. You can remove the head from the body, but the head needs to be submitted intact, and it needs to be kept chilled as it's submitted, but don't freeze it, because then you may destroy the virus and you may not be able to get a diagnosis. They're going to usually do direct fluorescent antibody testing on the brain tissue and the salivary glands. Histopathology of the brain, looking for Negri bodies, is not usually that was the old way to diagnose rabies. It's still possible to do it that way. And then for confirmation, they actually can take some of the infected brain tissue, inject it into mice, and look for, once it's incubated, then look at the mouse brain with the direct fluorescent antibody testing to confirm that indeed that animal did have rabies. For vaccination, you want to begin vaccinating at 12 to 16 weeks of age, and then repeat the vaccine in 1 year. And then, depending on whether you're using a 1-year or a 3-year duration of immunity vaccine, after that first-year booster, then you will vaccinate accordingly, or according to your county or state laws. If you're unsure of the animal's vaccination status, stray dog comes into you, you have no idea whether it's been vaccinated before, but say it's 1 or 3 years of age. When you give it that first vaccine, you still need to go ahead and vaccinate it in a year, even if that dog is older than a puppy. And we already talked about the fact that the duration of immunity is proven by challenge for rabies vaccine. Some of the 1 and 3 year vaccines are the same, but not all of them. You do need to know that rabies is a killed product. It has lots of antigen in it, and it has lots of adjuvants. Adjuvants are those non-specific immunostimulants that help produce a bigger, stronger immune response. So because there's lots of antigen and lots of adjuvant, you need to remember that rabies can also cause anaphylaxis. You can get a cutaneous vasculitis where you get this sometimes thin, hairless area on the skin. We usually see those in little dogs like poodles and Bichons, or you can get a nasty kind of long-term crusty lesion caused by the vaccine injection. And sometimes you can get a granuloma or an injection site reaction. One of the more interesting things is we already talked about the fact that if you give a killed vaccine, you need to booster it in order to get a good immune response. And now you're saying, well, how come we can just give one rabies vaccine? Well, obviously we wouldn't, with a disease that potentially is contagious to humans and fatal, we would not want to rely on our clients to bring the animal back for a booster in order for the animal to be protected. So essentially the rabies vaccine acts as its own booster because it has so much antigen and adjuvant that that vaccine stays in that one spot quite a long time, and it essentially boosters itself. But that's again why you need to vaccinate again in a year from the initial vaccine, because you may not have long-lived immunity at that point. Well, that should wrap it up. I'll look forward to your question and answer session, and I'm sure you'll have a lot of questions, but you can do a little bit of reading before question time, and I'll see you then. Good day.